Now I invite Dr. Jitendra, Assistant Professor at RIO, to give his talk on the, ultimately I would say that he would be the person who would be concluding and telling us all the benefits of Iris Claw IOL.
Good morning, everyone. I'll be discussing about the complication associated with the iris claw lens and how can we how can we manage accordingly for the better visual outcome. Now, for a retropupillary iris claw, we have to choose better option in deficient capsule. So, in respect of safety profile with minimal complication. So, it is important to assess complication associated with various options available for secondary IOL implantation. Now, one by one, the discussion about the complication. Now, first of all, the surgically induced astigmatism is associated with the size of the incision. So, retropupillary iris claw, we have a SIA less because of less optic diameter, 5.5. As compared to SFIL, we have a 6 mm optic diameter. But nowadays, we have a foldable 3-piece IOL, which can be implanted through 2.8 mm incision. Another complication is the pupil ovalization, as we are desired, round pupil are desired. But sometimes for the beginners, we have we encountered a horizontal ovalization of pupil. To avoid this, is a short video that describing that for a round pupil, our stab incision should be a post-limbal incisions and should be of short intercorneal length, so that when we enclave iris claw, it should be away from the mid peripheral iris, away from the pupillary border. When we go close to the pupillary border, we have a cat-eye reflex, and which result in horizontal ovalization, gently repositioning the iris in this case, and other end and enclaving it, or a desired round pupil is achieved. Another complication we can rarely manifest is transient IOP elevation, which can be as a consequences of iritis, pigment dispersion, and most importantly, retained viscoelastic. So, to avoid the viscoelastic to go behind the IOL, this is a short video describing that always implant a lens in presence of air. First implant the air, then implanting the IOL, gently rotating it and removing the IOL, so we prevent the viscoelastic to go behind the lens. Corneal endothelial cell loss are in retropupillary is very less as compared to SFIL. We have a longer surgical time, so around 20% endothelial cell loss occur as compared to ACOL, which have maximum number of maximum endothelial cell loss as compared to retropupillary iris claw lens. Cystoid macular edema can be found in these cases, but these are due to persistent vitreous traction. So, complete vitrectomy from the anterior chamber is must to avoid this cystoid macular edema. Deconflation is experienced with the can be experienced with the beginner surgeon due to insufficient primary enclavation, and 24% of the cases have iris atrophy with the retropupillary iris claw implantation. This is a short video. We are describing how to enclavate this iris claw, and is one end is enclavated, and gently from the other end of the iris claw, we gently reposit the iris, and other end is slightly enclavated the iris, and but suddenly it's the beginners. We didn't, it confirmed when we remove the viscoelastic, it suddenly moved behind the one end of the iris claw, get de-enclavated, and gently we move the iris claw in the anterior chamber and re-enclavate it. Decentration of lens also can be prevented. This is the tip of the forceps. This is a special forceps, iris claw forceps, that these tips of the forceps aligning with the notches in the haptic, so that we can get the centered position of the iris claw lens. Another thing we can do in this case, like before implanting the lens, we can have a primary marking, 0 and 180 degree, with a simple toric marker, just marking with the axis 0 and 180 degree, so that we can avoid this decentration of IOL. Now, to conclude, this implantation of retropupillary lens are associated with minimal complication. So, these complications can be avoided and managed effectively. It should be the procedure choice for secondary IOL implantation. Thank you.
question? What's your question? As you know, people, you can use, depending upon the inflammation of the surgery, routine cases, you can put, there is no problem, and they're not going to disturb any iris balance, so you can use the cycloplegic also, if required. If inflammation is there, if the otherwise routine case, one time you can put this mediatic also, no problem. Anything you can use. Anything you can use, no problem. Not going to disturb anything you can use, no problem. As you know, it is required only in case of routine cases. If in the phaco, if there is no inflammation, is quiet, usually it is not required. But if you think there is some kind of inflammation is there, event is there, for making for preventing any synecia, anything, you can put. So similarly, normal routine cases like other cataract protocol, you can follow same protocol. Any question? Thank you very much for your kind presence and patience hearing. And as I think this instruction very much will be definitely very much helpful to everybody to manage to solve the problem, to manage at the same setting. We hope the next conference we will see you. Thank you very much.